Good day everyone, and my name is Danielle A.S. Francis, and today I'll be dealing with the treatment of diabetes mellitus. Firstly, I want to let you all know, if it is you weren't tuning in before for the previous series, you can always check the Arouca SDA Church YouTube channel to find the previous presentations. They had dealt with the types of diabetes, the causes and symptoms. Okay, so today we'll be dealing with the treatment of diabetes. Alright, so basically we have here the diabetes management plan. First of all, you must consider healthy food choices. Right? You must ensure that the diet is a well-balanced diet, and that is important for anyone. Right? Also, physical activity, you must incorporate some exercise, whether it be a walk, a jog. Some sort of physical activity is important. For the diabetics, you need to check the blood sugar levels. You want to make sure that you have it under control. It's not too low, not too high, Also, the diabetes medication is important, and we will go through the various types in a bit. Okay, so basically, the therapeutic options we have here is the same lifestyle as I was mentioning before. That is an important part in the management of diabetics, as well as we have oral agents, meaning basically tablets, tablet forms, as well as non-insulin injectables, and then we also have on the other extreme insulin. Okay, so it depends on the age, the severity of the diabetes, if it is different comorbidities, meaning other chronic illnesses, these will vary, and the therapeutic options will vary based on each person. Okay, so this is just an idea as to your blood glucose level, what it should be like. So our diagnosis, basically, normal will be less than the 100, and this is the fasting blood glucose, first of all. Right, and the levels between 120 to 125, there you'll be showing pre-diabetic signs. It's not diabetes yet. However, you are at risk, and here in particular, lifestyle, your diet, your exercise and everything will come into play to prevent you from becoming diabetic. And then on the right side, we have the 126 fasting blood glucose. If you have two readings at separate times, then you will be diagnosed as diabetic. Okay, we also look at something called the HbA1c, and this is also another blood test done, also called glycolated hemoglobin. We look at this, basically once again I say that it's an individual management, so each person is different, dealt with differently based on their age. So, okay, the HbA1c of 6 to 6.5, that is more of a tighter control of your sugars. But this is for people who are more like young persons, who are more fit. They don't have any chronic illnesses and whatnot, and they're able to have a tighter control. We will be using that. However, most patients will be in between with the HbA1c of less than 7. Right? So the doctors will look at that range to keep the patients at. However, like for the elderly and those who are at risk of severe hypoglycemia, meaning sugars getting really low, we will try to extend the range to 7.5 to 8. Right? And those people who, once again, with different comorbidities like high blood pressure, heart failure, whoever had heart attacks before, you will not have a tight control as someone who is younger. Okay, so firstly we'll go into the non-pharmacological treatment. As I said, this is basically the nutritional therapy, and it's about the diet. You want to maintain a healthy body weight, so with exercise and diet, we can achieve this goal. Also, it will be recommended that a dietitian gets involved to help with the meal plans, because it is important you can have an idea as to the range of the types of food that you can eat, and the amount, the quantity is important as well. Okay, so for type 2 diabetes, you want to manage the caloric intake as well, because that can help with weight loss. Once you restrict the calories, certain amount of calories, that will be able to help with the weight loss and thus help you prevent getting hyperglycemic, right? Meaning too high and stuff. Also, with the exercise, aerobic exercises can improve insulin resistance, so it will help you be more sensitive to the insulin and also reduce cardiovascular risks such as heart attacks, strokes, and whatnot. All right. So it's also shown that with physical activity and dietary changes, the HbA1c is reduced to about a 0.5 to 1%, and that is really good, just by diet and exercise. So this is just a little pyramid, food pyramid, giving you an idea as to the quantity in how you eat the types of foods. So you really want to stay away or eat as less as possible with the processed foods, so all the fast foods, the sugars, you want to reduce that. You want to increase your vegetable and fruit intake, certain fruits to a certain amount for the diabetes. You have to watch all of that too, because that's a lot of sugar as well, depending. So, as I said, a dietitian is recommended just to make sure you're eating the appropriate amount. And also your legumes, cereals, they are all important. Of course, we would advise that you avoid smoking and alcohol. Okay, so this is just a briefing of the 3 types of diabetes. As I mentioned before, you can get a further briefing on that in the previous presentations. I'm just running through to give an idea. So the type 1 diabetes, as we say, they are insulin dependent, and therefore they need insulin because their pancreas basically produces little or none at all. Okay, so their plan will be lifestyle, the diet and the exercise and whatnot, as well as insulin. Type 2 diabetes is basically non-insulin dependent because their body, the pancreas is able to produce some insulin, however, it is unable to use the insulin appropriately. Right? So they may, depending on the individual, and once again, they may need just lifestyle and changes, or they may need some oral agents, meaning tablets, once again, or they may need insulin along with the oral agents. It varies. So we'll go further into the type 2 diabetes management in a bit. And then we have the gestational diabetes, and this occurs in the women who, during pregnancy, they are also placed on the insulin, as well as at times metformin, which is an oral agent. And of course, lifestyle changes is important. So as I said, we're going further into the type 2 diabetes mellitus approach, the management approach. So it's like a treatment intensification based on how the patient responds to the medication. So we have the diet and exercise, which of course across the board is needed. And then we have oral monotherapy, meaning like use of one medication, one oral tablet. Oral combination, it will be adding on another oral agent if the person is the control of the glucose, so the sugar levels is not good, they will add on another. Or they may go up again, where you can use injectable, non-insulin injectables basically, or add on insulin with the oral medication, or they can just put you on insulin alone. But as I said, the management for diabetes type 2 diabetes is an individual thing, and it's based on each person and how they control and the various factors that play. So this is just an idea as to the type of insulin preparations and their action times. So firstly, we have the rapid acting insulin. This is, of course, it acts rapidly, quickly. So it's in 5 to 15 minutes. Some of the examples are the insulin Lispro, Aspart, and whatnot. We have the peak time as 1 to 2 hours and duration like for 4 to 6 hours. And we have the short acting. So it's the regular insulin, like the Humulin regular, and they could go from the onset is like 30 to 60 minutes. peak time is 2 to 4 hours, and they last about 6 to 10 hours basically. And then we have the intermediate acting insulin, and this is neutral protamine H-DON, and this also starts like with the onset is from 1 to 2 hours. And the duration is basically 10 to 20 hours. The long acting basically lasts for 24 hours. And some examples are the insulin detamine and the insulin glargine. Those are what we have for the long acting insulin. As I said, based on each person, the doctor will prescribe whichever regime, and based on their weight and whatnot, they will start on a certain amount of units for the insulin. Okay, and they'll give you a regime as to how to take it morning and evening, right? So this is something, as I said, is each individual, it varies. Okay, this is just an idea as to what your blood glucose level should look like. Right, so for fasting, well, for diabetics, right? For fasting, less than 100 is good. Before a meal, well, 70 is low, but to 130, you want to have it in that range at least. You don't want it to go really low because you will get hypoglycemic, and that is an emergency basically. So you want to make sure you always check your sugars, as I said, right? You don't want it too low or too high. These are the extremes. So this is just an average as to where you should be at to get proper control after a meal. So it should be the glucose level should be 180 when you check it, should be around 180, well, less than 180. And before exercising, you, especially if you're taking insulin, at least 100. You don't want it lower than that. If it is you're going to exercise, and then you don't want it really low, and then you will become hypoglycemic. Okay, so you have to watch that. And bedtime as well is another thing. A lot of patients, they come in and their sugars are low, really, really low when they wake up in the morning and they're not feeling well, so they have to immediately eat. So you have to make sure your times and the glucose level when you check it before you sleep, it's not too low. Okay, so this is just an idea of the diabetic kit. This is what you will be using if it is when you're checking your sugars. We have the glucose meter, and the reading will come up on the screen there, and you have a test strip slot. So you see in the test strip on the right hand side there, you have to properly insert this because sometimes they put it the wrong way and it will not read, right? So the other end, the green end on this one here, shows where that is where the drop of blood is to go. You also have to make sure it's not too much, just one little drop will be sufficient, right? But before that, before sticking yourself, you want to ensure that you clean the area, clean the finger, because you don't want any infection, you don't want anything dirty going in there, right? We have the Lancet Device, and this is for the Lancet, the needles basically. You have to properly load the Lancet Device, and make sure not you don't accidentally stick yourself for unless you're ready to. So you have to load it appropriately. And yeah, if you need help with that, you can always ask your doctor, or you can always look it up to see videos to see how to use it appropriately. And on the right hand side is just some examples of the insulin syringes. It's just to show you the needle is not that big. If in case you are worried about sticking yourself, the needles are not that big, and it should be fine. This is a diagram basically showing you the insulin injection sites. So we have, this is basically you need to inject yourself in the fatty areas. So the abdominal fat as seen there, also the upper outer arms. You want to ensure, well, the superior part of the buttocks, so you want to make sure you have a good bit of fat, as well as the upper outer thighs. So you want to ensure also that you rotate where you inject yourself. You don't want to continue sticking yourself in the same area over and over again, because that can cause one of the side effects called lipodystrophy, where you can actually see it's reddening and thickening and getting hard. It could cause like hypertrophy basically, where the fatty tissue becomes hard, and sometimes if people stick themselves in certain places, you can get abscesses and whatnot. So you want to just make sure you don't do that. Okay, so you rotate the areas. It has different options where you can use, right? As I was saying, the adverse effects of insulin, well, the one which I described before, the lipodystrophy, which is the atrophy or the hypertrophy of the fatty tissue at the injector sites, what I was explaining before. And as I mentioned, the hypoglycemia is one of the other major side effects where we really are concerned about. It is an emergency. So some signs and symptoms of this is headaches, anxiety, tachycardia. Tachycardia means your heart racing fast. You become dizzy, you're cold sweating, you're just feeling nauseous kind of way. You're not feeling yourself. Okay, and sometimes people lose consciousness or get into a coma. So this is a serious problem. So as I said, checking your blood sugar levels is important, and do not use the insulin if it is you have not eaten, if you skipped a meal, or if it is you did not check your blood glucose level. Don't just take your insulin like that. You need to know. Okay? Alright, so now we will go into the oral agents and the non-insulin injectables. So as I said, we are stressing this is on the type 2 diabetics. Okay? So these are some of the options that they will use, including the insulin if need be, but most times the oral agents and the non-insulin injectables are sufficient. Right, so we have the first one, first-line treatment. It's actually been used for so many years and has been proven to be really good. Metformin, as a lot of you will know it by, or glucophage. Right, so it's one of the bigger NIDs. That's the class of the drug. And basically it decreases the production of glucose, right, within the liver as well as in peripheral tissues such as the muscle. It also reduces the HbA1c from 0.5 to 1.5% around that range, so that is good. Also, other advantages are it is inexpensive, so you can purchase that and and you will be fine. No hypoglycemia, so that's a good thing, as well as no weight gain. Okay, so with insulin you can gain weight, but with this one, metformin, you don't gain weight, but however you will have some side effects, of course. Some people use a lot of mostly gastrointestinal disturbances, like nausea, vomiting, depending, or upset stomach or something like that. Also, we also would want to monitor for patients who would monitor their renal function, because there's also a risk of lactic acidosis, and that is a serious side effect. So patients with renal problems, we will want to watch with the metformin with that, because you want to avoid lactic acidosis. Then we have the insulin secretagogues, and the class is sulfonylureas, and these examples I have here, like the glucoside and the glipizide, these are second generation medications, and these are very effective as well. However, they act on the pancreas itself, the beta cells of the pancreas, to help secrete that insulin. Okay, it's inexpensive and very rapid acting. However, once again, risk of hypoglycemia and the same gastrointestinal disturbances, but this one also causes weight gain. Right? The metformin doesn't cause weight gain, but the sulfonylureas cause weight gain. So a lot of people may tend not to use this one. And then we have the meglitinides. And this also acts on the pancreas as well, but a different receptor. And it can reduce the HbA1c at a range of 0.8 to 1%. And the dosing is flexible. So it has its advantages, and its disadvantages are similar as well to the sulfonylureas. Then we have the Thiazolidine Diodes, and this is another class where they increase the peripheral glucose uptake. Meaning, so like in once again, also they decrease the glucose output of the liver. So it acts in like two ways, and then The advantages of this also decreases triglycerides by 10 to 20%, so that's good. It increases HDL. HDL is the good cholesterol, so you want that to increase actually. So that's really good. You don't have any hypoglycemia, and it is relatively inexpensive, right? And you don't need to adjust the dosage for if you have renal disease, right? So this is actually very beneficial also. But however, weight gain, so that is, another problem. Then some patients may be at risk of heart failure, and it increases the LDL, right? And LDL is the bad cholesterol, so you don't want that to be increased. Also, patients with bladder cancer should not use this medication, okay? So then we have the alpha glucosidase inhibitors, like acarbose. I don't know if you all know it. They slow down and decrease the digestion and absorption of polysaccharides, which is the complex sugars and stuff, as well as the sucrose, like disaccharides, which is, a simpler sugar than the complex ones. Then we also have the advantages where no hypoglycemia, it's weight neutral, so it doesn't cause weight gain, it remains the same. Of course, once again, the same gastrointestinal effects, and you want to avoid giving this in patients with renal disease. So if their creatinine level, so this is one of the tests they do, if it is more than 2, you will not be given that renal patient this medication. Okay, so we also have another class called Dipeptidal peptidase 4 inhibitors, Cytoglyptin. Maybe some of you have heard of it. It inhibits the DDP4 protein, basically, and this causes it to increase the insulin secretion, and it lowers glucagon secretion, right? It also reduces the HbA1c of 0.5 to 1%, and it doesn't cause any hypoglycemia. It doesn't cause any weight gain. It actually decreases blood pressure, so right, and it decreases the glucose after meals. Pancreatic disease, we want to avoid with that may have risk of arthritis, and it's relatively expensive. But other than that, those are the ranges of the advantages and disadvantages. Then we have the glucagon-like peptide 1, exenatide, and this one basically enhances the glucose-dependent insulin secretion, right? So it also reduces the glucose production in the liver. Once again, no hypoglycemia, that's good. And this one is a injection one. This is the non-injectables, as I was mentioning. So one of the disadvantages, if you don't like needles, is this, because it's an injection basically, right? And you also have gastrointestinal effects and concerns of acute pancreatitis. So it could happen. Not all the time these are the side effects that everyone will experience, okay? But it also has good properties where it is cardioprotective, meaning, it can help decrease the risk of a stroke or a heart attack, right? And it also causes weight loss, so that is really good because it decreases your caloric intake, okay? Causes you to not really eat as much. And then we have a new drug on board, sodium glucose co-transporter 2 inhibitors. And those are just some of the examples there. And they inhibit this protein and this co-transporter, and it causes reabsorption of the glucose in the kidneys actually. So that is a good thing. And it lowers blood sugar levels. Okay, so you have weight loss with it, which is good. No hypoglycemia, and it also decreases the risk of cardiovascular disease or congestive heart failure. So this is actually promising, and it decreases renal function. Okay, but however, they noticed that some of these side effects are actually like urinary tract infections and some genital infections also. It also could increase the bad cholesterol, which is the LDL, and a risk of diabetic ketoacidosis. So this is another emergency, but the side effect is rare, right? It really happens, and it's relatively expensive. So these are some of the classes of the oral agents. As was mentioned before, your doctor, as if you could recall the stepwise management, you will not be prescribed all of these, of course not. So as I said, they might do an oral monotherapy, so metformin will be the first line. But however, some people may not be able to take metformin, so there may be contraindications to taking it. So then they'll have to use another agent. Or if it is they're going okay with the metformin, however, if the control is not as good as they like it to be, they may add on another agent such as the sulfonylureas. And they keep the medication, they can interchange, they can add on insulin depending on the range they are trying to target for that person. So as I said before, it's also important that you have an idea as to your medications. So it's good to know when patients come in to casualty, to emergency, and they're able to tell you the name of the medication and the dosage and how they take it, right? So if it is you can't remember, it's always good to come with your prescription when it is you have an emergency, because that in that case, the doctor is able to have an idea as to what you are taking. Okay, so we're just looking at some routine evaluation of the patient with diabetes. It is important to do retinal exams meaning with the eyes, because there is retinopathy, basically with damaging of the vessels of the eyes and whatnot. So, and glaucoma, you want to prevent these problems. So at diagnosis, the doctors will check the eyes, as well as they'll do this annually, okay? Because especially if it is you also have high blood pressure with diabetes, you need to check your eyes often, right? At least annually. And then we will check the HbA1c every 3 to 6 months, as I told you before. This gives us an idea of the glucose control for over 2 to 3 months. A complete foot exam at least annually. It is important. A lot of diabetics, they are at risk of ulcers and could lead to amputations, and you don't want all those complications. Okay, so it's really good to check your feet. We may do lipid tests, so that's like for cholesterol basically. Every year at least, we will check that as well. We also check the urine for the microalbumin creatinine ratio for the protein and whatnot at diagnosis and annually. And also some blood chemistries, renal function and whatnot every 6 months. So we will do certain blood tests just to give us an idea as to the general health of the patient, okay? Because as with diabetes, you are at risk of cardiovascular disease. So we would like to check all these different things, and we would like to continue checking the HbA1c to give us an idea as to how the sugars are controlled. So once again, as I mentioned, feet care is important. So I just decided to go through a slide with you so you can have an idea as to how to take care of your feet. So you wash your feet with warm water and soap. Of course, not hot water. You want to scorch your feet, and then you dry it thoroughly. Dry in between the toes. That is important. And you should moisturize your feet. A lot of times with the diabetic foot, it's scaly and it cracks a lot. So, and that as well could cause problems. So you want to moisturize your toe, in between your toes and your feet. Also, you check underneath your feet with mirrors to see if any cuts, any blisters, anything. Because with diabetes, as I said, some patients are unable, they experience something called peripheral neuropathy, and they are unable to feel sensation in their feet or even in their hands, depending on how serious it is. And they step on things and they get cuts and they're not aware. And then this is where the complications come in. Right, so you check the toenails, ensure that it kept low. However, you don't want to cause any problems with the toenails as well. So you want to be careful when you're clipping them. Wear socks. Do not walk barefooted. Too many patients walk barefooted and then they come in with ulcers and whatnot and gangrene and lose their feet. Yeah, so take care of their feet. Wear proper fitting shoes and comfortable, and yeah, just keep checking, making sure no ulcers. Okay, so that is it for the presentation. I hope you were properly informed and you understood all that was said. Also, if it is you need any further information, you can always ask your doctors, if it is whether or not it's your general practitioner or at the local health center, if you're in the lifestyle clinic or even in one of the hospitals, the clinics there, you're able to get these prescriptions for the drugs and you're able to get it at the pharmacies or whatnot. So that's it for now. I hope you all tune in again for the next series where we go further into other treatments, other alternative treatments with the diabetes. Okay, thank you. Bye.